Hi, and welcome to Unity in Immunity, our panel discussion today, talking about vaccine safety, vaccine awareness, and more with our special panelists today. We're in Washington, D.C., and we're talking to some special guests. I'm going to go from left to right and introduce them and then allow them to introduce themselves. So, first, I'm going to introduce Dr. Jamar Slocum, Assistant Professor of Medicine at the George Washington University School of Medicine and Health Sciences. Dr. Miranda Ward, Associate Professor of Clinical Research and Leadership from the George Washington University School of Medicine and Health Science. Ms. Anna Williams, Senior Center Administrator from the Center for Population Health Sciences for Health Equity. And Ms. Siobhan Onama, Associate Professor of Medicine at the George Washington University School of Medicine and Health Sciences. So we are so excited for you guys to be here today to talk about vaccine safety. We know that vaccines, just in terms of the awareness and the discussion around vaccine, is one that is very politically charged, but also just one that people have a lot of questions about. People are talking about amongst themselves, but a lot of times people don't have all of the information. We know that there's a lot of information on social media, and we thought, you know what? Let's talk to the actual researchers, clinicians, the doctors, and the folks that work in this public health space to really get the answers to be able to clarify it for everyone. So, first off, level set, and let's just frame the why about vaccines. For one, we talk about vaccines and taking them one at a time, whether we're talking about the flu vaccinations, shingles, pneumonia, HPV. How do you frame vaccinations as a holistic approach for keeping patients healthy across their lifespan? And I'm going to direct that one to you, Dr. Jamar.
Well, together with clean access to water, motor vehicle safety, vaccinations without a doubt has increased our life expectancies and reduced infant mortality. Vaccines is one of the greatest public health achievements that we have seen in our lifetime, and specifically in the 1990s as well. WHO predicts that vaccinations prevent 4 to 5 million deaths per year. And it's one of the most cost-effective ways that we can deliver public and population health to our population.
Wow. I mean, when you put it in those kind of numbers, that is really, that really drives home why vaccinations are so important. But we all know, Dr. Miranda, from your experience, how has vaccine hesitancy evolved since the COVID-19 pandemic? I mean, we remember going to school and you just kind of went, got your vaccination, and that was it. But now there seems to be a lot more hesitancy that's come up, particularly since COVID-19. What are you hearing from your patients that's different from before? And how has hesitancy evolved since COVID-19?
So thank you for the question. Let me start off by noting that I'm actually not clinically trained. So I'm going to be offering my perspectives as a medical educator. And the first thing that we need to do is do a language check. So today, I think it's going to be really important for us to frame this discussion as building vaccine confidence rather than focusing on vaccine hesitancy, because just thinking about the word vaccine hesitancy, what that does is, first of all, it just pathologizes entire groups of patients that have the right to have reservations and questions, given what we know about medical and scientific racism, research abuse, and research exploitation. So what we don't want to do is not acknowledge that history. And let me not even say history, because yes, there's some of that is historical, but we also see it in very contemporary times as well. So that's the first thing. And so also, if you think about the concept of vaccine hesitancy, it's very much coded language, and it's another way of saying non-compliant. And so if we want to foster rapport and relationships between patients and their clinicians, we don't want to refer to them as non-compliant when they have the right to refusal. When instead we want to explore what are their questions and actually respond to those questions. So I think it's really important for us to think about the fact that there was a study that was actually published in Health Affairs talking about Black and Brown patients being more likely to have coded language actually in their electronic health record. And that language was calling them difficult. It was calling them non-compliant. And we know the electronic health record follows you around. And so no matter who pulls up your chart, they're going to see that before they even see you. Before they open up the door to introduce themselves, they see that you're difficult and you're non-compliant. So now that's going to color that experience, and they're going to be potentially less likely to share with you the range of treatment options because you're non-compliant. They're going to be less likely to, maybe share a clinical trial that you might be eligible for because you're difficult. So this is why we don't want to bias that encounter and not use that language. Language is power. Language actually frames the entire interaction. So I just think it's really important for us to practice that, that language modeling right here today.
Got you. I hear you. So vaccine confidence and not vaccine hesitancy. You're absolutely right. So how do people avoid being labeled like that in their electronic file? How do you keep from doing that?
You know what? I'm so glad you asked that because at the George Washington University School of Medicine and Health Sciences, we actually do have a coalition of clinicians that have been doing that work. So, for example, one of the clinicians in the infectious disease team has been working with the team to actually call out some of that language. And they actually decided, you know what, we're not going to refer to our patients as non-compliant. Instead, we're going to do the deep social screening that's necessary to figure out why they actually didn't, take all the pills or do whatever it was that, that we talked about in the clinical encounter. And what they're finding is, maybe it's actually because there's food insecurity, right? Instead of calling them non-compliant, that's quick to be dismissive and actually kind of really hone in on the issue at hand. So we realize that language like non-compliant is very much, we've been socialized, let's say that when in medical education to use that language, it is going to take some time, to kind of think in different ways and new ways to ways that we want to frame the interactions with patients, but it's very much worthwhile.
Interesting. Thank you. Thank you. Before I move on to our next panelist, I'm going to ask you, Dr. Jamar, what are you hearing from your patients following COVID-19 in terms of their confidence around taking the vaccine versus before COVID-19?
So thank you for that question, and thank you for having me here today. I would say that when we talk about, vaccine skepticism or any type of hesitancy, that this did not occur overnight. And while the COVID-19 pandemic was one of the most impactful public health threats that I've seen in my lifetime, the skepticism, the hesitancy that a group of people that have been marginalized, this has been going on for some time. And our expectations as clinicians, public health practitioners cannot be that we can solve this overnight. We have to have the expectation and the belief and understanding that we are expecting a group of people to believe in institutions that were not developed and built for their benefit. So our job as professionals is to empathize with them, to understand where they're coming from, their backgrounds. And because their challenges for why they're not doing or taking the vaccines are all different. And so we have to build those systems, understand, work with them to break down those barriers.
So we know that we're not a monolithic population. So really, it's amazing to know that you guys really are able to take that one-on-one approach. And that's very helpful to our community because we are so different. Dr. Onoma, wanted to ask you, many patients think I'm healthy, I don't need a shot. How do we help them understand that vaccination is about prevention and not reaction?
That's a great question. But might I just add a little bit to what a couple of my colleagues have
Absolutely,
said
yeah.
here? Because, as a physician, primary care and HIV specialist and medical educator, some of the questions you asked really just this morning, had a conversation. And I just want to highlight the language piece that Dr. Ward talked about, Miranda. In that, for instance, our patients now can see their records too. They can see their medical records. And we might document that a patient refused the vaccine. And much to Dr. Miranda's point, we can then, that patient, I actually had a patient reach out to me and say, well, why did the chart say I refused this? Actually, I just wanted to talk to my doctor, right? I just wanted to know what are the pros and cons. And so even saying, hey, these are adults and they get to choose and decline, I think that that is important as well, because even that term refusal can kind of change the dynamic. And I think the other piece, when as you talked about COVID-19, I actually with my patients feel like initially we did a lot of work as a medical community to try to build vaccine confidence. And yes, of course, we still have more work to do. And however, what I'm seeing more recently now, like even this morning, my patient said, "Well, I got all my COVID boosters before, but I don't know about this new one." And honestly, I said, "Well, why?" I think that's the biggest piece for me because I build a relationship with my patients. I'm always wanting to know why, and I just want to make sure that they're making an informed decision. And she said, "Well, I don't know that I can trust this one." She wanted to know more about the research. When was this vaccine developed? Is it the current administration? And those are real questions. And so I was able to walk through that with her. Fortunately, right now we can say that the vaccine was developed before the current time. So yeah, so I think that that's important to really get to that why. But now to your question about, prevention. And so, I use a lot of analogies with patients. I try to see, like I said, relationship building and figuring out where people are coming from, what's important to them. And, so for instance, as a primary care physician, I'm asking about, do you wear your seatbelt? Do you have guns in the home? Those types of things. So just as someone wears a seatbelt to try to protect themselves from a car accident, we don't know what's going to happen. That's the same type of protection as a vaccine. So it like to your point, it doesn't matter if you have chronic conditions. Yes, of course, if you have chronic conditions, diabetes, kidney disease, lung disease, or your immune system is down, you are at increased risk for, complications from these viruses and other and bacterial infections too that we vaccinate against. You can still, and we have, and I share stories with people too. I've had young folks without medical conditions on ventilators, people that have lost lives. And so I think storytelling is really important too, and understanding that, for instance, if we use COVID, for example, when we looked at those that were hospitalized and on ventilators and ECMO and really advanced organ failure, the vast majority of those folks had not been vaccinated once we had a vaccine available. And I think that that's important for people to realize as well. So I really just try to meet people where they're at and relate to them and hopefully find something that they're passionate about or something that they do believe in and help them see how this is very similar with vaccinations.
And it can be very difficult also, I know. Anna, one of the things that comes up is sometimes patients think that vaccines are for kids. They don't think about being part of the older generation and that adult and older populations need vaccines too. I know there's even a vaccine now that is geared towards 65 and up populations. You guys get the word out that vaccines are not just for kids and those kind of, go to the doctor school physicals, but that you still have to get them as you age.
So, one of the things I think about from a public health perspective is framing and making sure that patients and the population in general understands vaccination as an ongoing process. And so, vaccination is the first step to building an immunization against whatever the vaccine was for. And part of what that looks like, and we saw it play out with people who were getting the COVID-19 vaccinations, that there were series of shots. It wasn't always one shot. And so that conversation around it being ongoing, how vaccines lead to immunization, how immunization affects the population overall, helps frame it in a way that I feel the population begins to understand that this isn't a one-stop shop. What I did when I was 6 months or a year old was for one set of immunization that I was building, and that's the foundation level. But then as I age, there are different things that I may become exposed to that I also have to build immunization for, similar to monitoring blood pressure or, taking your medication and seeing how that's interacting with your body over time. Immunizations and vaccinations, I think as a process, is the most important piece to getting people who are older that feel like they already did it can re-engage with the process because it does change as we change.
I mean, that also brings me to another question. Dr. Onama, what about when adults start with their vaccines, but then they end up missing a second dose
Mhm.
or they skip the recommended vaccines like pneumonia or shingles, especially in immunocompromised older patients. What do you do? How do you kind of keep the consistency going? How do you talk to them about the missed doses? And then if you can tell us a little bit about your work with Dr. Ward and how you both have worked with
Mhm.
immunocompromised adults.
Absolutely. So first, I think it's really important to normalize that we are all human. And so missing a vaccine, sometimes missing a medication, missing an appointment, these are this happens. And so we don't want to shame people. Okay, you didn't get the second shot. We just play catch up. And a number of vaccines really, we have the recommended dosing is so that you can build up the best immunity, and it needs to have enough space between so that your immune system can basically react to the protein particles or whichever the type of vaccine, however that vaccine is made, and helps us build antibodies so that when we actually are exposed to that infection, our body can respond appropriately. So it's more so usually about the spacing and that is there's enough time. But if you do have a delay, that's okay. Let your doctor know, and we can usually just play catch up, right? And the second part,
Okay, so the second part of the question was making a reference to a national training effort for clinicians to, build their capacity to routinize HIV and COVID screenings in the one primary care setting. So I was a PI on that national effort, and we know that there are so many clinical screening guidelines, right? That clinicians have to keep up with, right? So in this particular instance, they had to know the HIV clinical guidelines, the PrEP and PEP clinical guidelines, which by the way just were updated. They had to know the COVID guidelines, which were constantly changing. So one of the first things we wanted to do after we had this national advisory board, we did research, we talked with clinicians, we talked with minoritized patients, and got in their perspectives. Is that we wanted to create vignettes of clinicians talking to clinicians to create the value for, because if you think about it, the primary care clinician has so many things that they need to do. You got to do a depression screening, got to do substance use disorder screening, got to do, right. And they were like, okay, also make sure you do PrEP and PEP and right. So we knew there was lots of things we kept adding to the primary care, set of screenings. And so that's why, we had a range of clinicians like Dr. Onama who came on and said, you know what, I will gladly be an ambassador. And she had basically created a vignette where, her as a clinician talking to other clinicians about the value of yet, yes, another screening conversation that needs to be had in a prevention-based setting like primary care. And then ultimately, being able to build their capacity to feel comfortable and confident and actually having those conversations in a way that was culturally responsive.
Thank you for that. Anna, that leads me to a question on how do you work with and partner with clinicians to build trust in communities, minority communities, and communities that might need to work on having more vaccine confidence? How have you partnered in the past and how are you partnering now?
So in the past, I worked from a policy perspective in coordinating efforts either with individuals who were employed at the CDC and DC Health during the COVID-19 pandemic. And then currently, something that's central to our mission is just making sure that we are actually preparing clinician citizens for engaging in community-led
Mm.
programs, right?
That's
It's
key.
not
That's key.
exclusive to vaccines or building vaccine confidence.
Just community-led in general.
Community-led in general, and what that means is using the data from community health needs assessments, conducting community health needs assessments where necessary, going out into working groups and forming and convening working groups with community organizations, community members, residents, leaders, to find out what they need that maybe doesn't get reflected in some of the data that exists as it's been collected, and then selecting priority focus areas from that information. And so when we put out, requests for proposals for any sort of like earlier mid-career training for faculty and clinicians who do want to learn how to do community-led research, we are very specific and very intentional about asking for proposals that focus on those priority areas that our community has identified. And so that's where we start to build the foundation by inviting clinicians in to focus solely on the priorities of the community.
What are some examples of some of those priority areas that you guys focus on? And have you found that that method to be successful?
Yeah. So, I mean, one of the things that we're focusing on is like cancer prevention and treatment, and just working with community organizations that have already been doing the work, right? Because as a center, we haven't been here in perpetuity, but the work has. And so there are some community organizations that already had relationships with certain clinicians. And so even though we might identify that priority area, what we find the minute we engage with the community is that they do have a name or two in mind that's a clinician. And so we automatically just join the conversation and begin to provide support and assistance wherever we can.
Thank you. That's excellent, and I love that approach right there. Dr. Onum.
Yeah, no, I was just going to comment. I think just driving home the point that that community-led focus is so huge. Was working on a proposal or grant actually with the city for colon cancer screening prevention, and we worked with a faith-based group in the city. And what we found with both our residents and the community members, we did some focus groups and really tried to understand from them what their barriers were, their perceived barriers to improving colon cancer screening. And so similarly, we can do that with vaccines, and it has been done. There's literature to support that. And I think what happens is that sometimes we as medical professionals think we have all the answers, and you find out actually the community has the answers. So the things that we think, oh, they need more education or, and no, that's not. They're like, no, we actually need transportation. We need chaperone services because I don't have anyone to pick me up. And so that was something that we were able to work with another local community group to provide. And so I think really focusing our attention to the community and allowing them to give us the answers and we partner to help provide the bridge is really important. So thank you for the work that you're doing.
That's a wonderful approach. And I think that also carries over probably to a lot of other areas. And you're right, it's so important. Most times the conversation is, oh, there needs to be more education. There needs to be more education. And you're right. Sometimes it's just a matter of asking the community itself, what do you guys need? What is the issue? It's like strolling to the polls. It's like sometimes we need a ride to get to the polls. Sometimes we, it's not always what we think it is. And it's great to just take it to the community. Now, a lot of times also, Dr. Slocum, I want to say sometimes there are people, though, that have been listening to things on social media, or you hear something from their cousin or at the barber shop or something like that. What do you find when people come to you, patients come to you, and they're bringing information that they've heard? Oh, I don't want to be a test subject. I don't trust what's in the shot. Or things that maybe have been discussions that have been carried out online or something. How do you respond to those kind of comments? What strategies, I guess, have you found to be the most effective? Maybe not exactly what you say, but what strategies do you take?
It starts with listening, obviously, and building that relationship and understanding that people have their own right to be skeptical about certain things. And we all have our own lines that we don't cross. And so I personally have family members who may not get vaccines, and I still love them just the same. And I don't chastise them or deputize them or have any expectations that they have to do what I expect of them to do as well. So it's really about building that relationship and understanding that maybe they don't take the vaccine at this time. Maybe they have questions and maybe they're not ready at that given moment of time to take the vaccines. But it's really about focusing on that relationship, building that trust, being transparent with them about what their beliefs, what their causes are, what some of the health conditions that may happen if they don't. But I feel like you don't want to get rid of that relationship first. So I always talk with them. I try to build a rapport with them and meet them where they are.
That's so important. Dr. Miranda, what do you think about that strategy? How do we address misinformation, especially on social media, without alienating patients, like Dr. Jamar said, really keeping that relationship with the patients? Sometimes patients are simply unsure. What is the strategy that you take? How do you address it? And how did you do that with your 2-in-1 campaign? Maybe you can tell us about that as well.
So let me pick up on where Dr. Jamar left off on meeting patients where they are. I think that's so critically important. And I think that's where we have to remember how people make decisions, right? People don't just say, I'm either going to do it or I'm not. No, right? There's literally health behavior theories that explore how decisions are actually made in stages, right? So right now, the way we have the health information is typically kind of like a one size fits all, right? Typically it's kind of like, oh, get your flu vaccine. Okay, wait, let's talk about this, okay? And there's nothing wrong with that message, but that message is for a one segment of the population, right? So let's think about this particular model, right? There's a model that suggests that you actually walk through multiple stages. You might be in the pre-contemplation stage, meaning you are not even thinking about it, you never heard of it, right? So get your vaccine today, it's not going to work for you because you don't even know what HPV is, right? So how are you going to know to get the HPV vaccine? So if someone's in the pre-contemplation stage, they need a different message than someone else who's in the maintenance stage, meaning I've gone through all the stages. I just need to get it every year, right? That kind of get your vaccine today message is for the maintenance stage, and you bypass all these other stages. You go from pre-contemplation to now you're contemplating it, right? Now that you've had this conversation with your trusted clinician, they've answered your questions in a non-judgmental, compassionate way. They've given you all the information, including any potential side effects, right? So that you can make the informed decision for yourself and your family. Now you're considering it, right? And also, I think we should celebrate those wins instead of just, did they take it or not? No, no, no. You know what? They went from not even considering it to now considering it. That's a win. So we need to actually celebrate wins along the way for how people make decisions. And then maybe they're planning to act, right? They're, okay, again, getting information, they're asking a couple of friends, all the things, go online, then they actually act, and now they need to maintain it. So I think that we need messages that actually cater to each of those, what, the ways we make decisions. Because when we use the kind of cookie cutter, okay, just get your vaccine today, there's a missed opportunity of engagement. And that is leaving the window open for misinformation. They got to get their information on their own instead of actually having messages crafted for them on where they are in the decision-making journey. So it's okay if you don't have a background in health communications, right? Get somebody on your team that does, right? So that you can make sure that you understand these stages and your messaging needs to meet people where they are.
That leads me to a wonderful question about how can clinicians across specialties, whether it's primary care, pediatrics, geriatrics, OBGYN, internal, pharmacy, how can they work together to promote a unified vaccine message? Or is that even possible? I mean, we're gathered here to talk about unity in immunity. How do we kind of unify about that? Siobhan?
Just highlighting a few different points here is probably the biggest thing we need to do is make sure people know we actually care, right? There's that quote that no one really cares how much you know until they know how much you care. And so no matter what your specialty is, whether you're a physician or a nurse or public health or policy, really, making sure that people know that this is for you and for you as an individual, but then also for us as as a greater community. We talk a lot about herd immunity and how, to your point, maybe if I'm young and healthy, the chances of me having a complication from any one of these infections may be low, but my grandmother or my child who cannot be immunized or for whatever reason, perhaps me taking the vaccine, and not just me, because herd immunity means that a large number of people need to take that vaccine, we can help others. And so we have to think about that as a unifying message, and that this is about caring for ourselves and caring for one another. So I think that that's one way, partnering and not working in silos. So for instance, we're all up here from different, sectors. So that community having spaces like this where we come together and figure out what works. I think professional societies is another great way where people talk about what has worked within their institution or their organization and the collaboration which can be really, really effective. So I think those are some of the techniques that we can do. And then, so meeting people where they're at. So as you mentioned, social media, people are using social media. And yes, some people trust the barbershop or whatever someone said on TikTok, more than they might trust their physician. Then we also need to be in those spaces as well, right? And delivering these messages and delivering them in ways, not in a paternalistic way. So that's the beauty about why I went into adult medicine, is that, my patients are adults and I respect your decision. My job is really to make sure that it's informed. And so I'm giving you the information. I understand why, if you're not, going to decide to participate in a given treatment plan, that I understand why. And so that I can, to Dr. Miranda's point, figure out, okay, where you're at. Can I give you information, or can I help connect a story again to get you to that next stage? And it's okay if you still at the end of the day say, you know what? I'm going to pass. And thank you very much for sharing that information. And I know I have done my job. And I think that taking away that, historically medicine was so paternalistic, and that's why we're in this position that we're in with, doing experiments and sterilization on patients without consent and things of that nature. And so we have to recognize this is a partnership and we're not their parents. This is a partner. These are their bodies.
I
Respect.
love that. And, and people talk a lot about how quickly they're in and out of their doctor's offices and everything. And I think sometimes it might be a matter of taking that extra few minutes to have that conversation where people don't feel rushed. Sometimes at the end of an appointment, it's like, oh, I see you're due for your flu shot and you're this shot and this shot. And people might just be fearful because maybe they're fearful of shots in general, or maybe they're whatever, or maybe they just need that extra conversation to feel confident about it before they do it. And taking that extra few moments to just say that to them where they don't feel pressured
Right.
and they get a chance to make a decision. And like you said, that decision may not be the decision that you want them to make, but having that conversation might just be where we get more, more unity in the immunity.
Absolutely. I'm so glad you mentioned that, because I get it. Those appointments are fast and we are short on time. But one thing that we've done even in our clinic this year that's been really helpful is that our medical assistants, when they're rooming the patient, they're already asking, are you going to get your flu shot? Are you going to get your COVID shot? Or whatever vaccines that we have available, and they can see that they're due for. And then they are color coding the appointment so that they know if the patient declined. We know as a physician, if the patient declined, or if they're thinking about it, they want to have more conversation, or if they had already received it, maybe, at a prior visit or at the pharmacy. So that has been really helpful, because now that patient is already thinking about it before I get into the room, and they know I'm going to follow up that conversation and see where they're at in that process. And so also using other members of your team, it just doesn't have to be a conversation with a physician. You have medical assistants and nursing and what have you too.
I love that. It's a whole team discussion. So it is working together and building up to it too. That can also help with the confidence. Well, Jamar, I would say Siobhan brought up something interesting too when she talked about the herd immunity. Let's talk about a little bit about community immunity or herd immunity. How can you protect those who can't be vaccinated, such as newborns or certain cancer patients, or who else falls into that area? And with there being so much division among people now about vaccines, are we truly able to reach herd immunity?
So I like to think about herd immunity as a large percentage of a designated population that is vaccinated or immune to a specific pathogen. And when that occurs, there is a reduction in the transmission of that specific pathogen. And ultimately, those that cannot or will not get vaccinated are protected. Now, the appropriate level of vaccination that has to occur differs based on the population, the size of it, how contagious the vaccine is, the density of that population. And so it requires a collaboration with science, the society, and policy to ensure that we can get that appropriate level of immunity that occurs.
Got it. So that's fantastic. Okay. So that's very interesting. So now, Dr. Ward, what are the things, going back to the conversation about how different clinicians across specialties work together, what role do you think peer-to-peer conversations among clinicians play in boosting overall vaccine confidence? We have a group like now where you're talking to one another, but how do those peer-to-peer conversations work in terms of?
So that was one of the things that we mentioned earlier with the 2-in-1 model, and how we did rely on the peer-to-peer exchange and the vignettes of clinicians talking to other clinicians to create the value. And I think that, I've always been a big fan of peer education. And so, this is a form of peer education, right? Because the one clinician is talking to another clinician. And I feel like, because, as a clinician, you know what it's like to actually have to navigate those relationships with patients. And I remember a conversation on another BDO panel, actually, when one of the clinicians mentioned how, going back to Dr. Onama's point, clinicians are human, right? And so sometimes there can be fatigue that sets in, especially in this social political climate where, some physicians just don't want to sit there and argue with the patient, right? It's kind of like, okay, they have the right to say, no. And so, just kind of going back and forth, that's just not helpful for creating that reciprocal relationship. And so that's the thing. I feel like if we know that a patient, and I'm sure that any of the clinicians can jump in, if you know that a patient actually has misinformation, which is one of the more popular ones, or more common, misinformation about vaccines is the connection to autism, for example. And if they
Yes.
come in
Uh-huh.
saying that, as a clinician, you have the responsibility to say, actually, because, all that aside, and you have the right to decline, but also let me explain this and that there's no connection. Those studies have been thoroughly debunked, all the things, right? So I think that, yes, maybe after a while, you don't want to necessarily kind of keep going back and forth when they've made their decision, they made it clear. And still, the information needs to make sure you walk out of here with medically accurate information. So I'm going to take the time to do that, right? So I think that that's where that peer-to-peer modeling is important, so that some clinicians who maybe don't feel comfortable, they feel like they're arguing. It's like, no, it's not an argument. It's literally a discussion, right? So I think that if another clinician explained it to them, it's not antagonistic. It's you and your role as a educator, right? I think that that would bode well, and it might fare better. So I don't know if either one of the clinicians want to step in, but I think that we've seen that that's definitely been the case when we've used clinician vignette to create that value.
I think that's fantastic. I mean, that's really important. Like you said, it's a responsibility and not just, something about whether you should do it or whatever. It's your responsibility to step in. And that lends myself to a question I was going to ask to Anna. How do we rebuild trust in science while staying sensitive to the cultural and community context? So, I mean, just like Dr. Ward was saying, it's not an argument. It's not about, trying to argue with people about their beliefs and everything. It's the responsibility to actually debunk certain things with the actual science. How do we rebuild the trust in science and stay sensitive still to the cultural and community context? It's a fine line for sure.
I think there are layers to this question.
Absolutely. Absolutely.
Because the way it's worded, and this is me like full policy wonk. If we're truly going to be sensitive to community and cultural context, then in some communities we aren't rebuilding trust, we're building, right?
Yeah, oh,
Not all communities
Yes.
have trust in science. Not all communities know how to differentiate between what's evidence-based and what somebody repeated multiple times to the point where everyone just assumed it was accurate and fact. So I think the first thing we need to do as the people who are the professionals, especially being aware of how society overall has shifted its idea and value, the value it places on what a professional is or what an expert is identify in the cultural and community context that within wherever it is we're working, whatever, if it's vaccines in this case and building vaccine confidence, identify those communities that have subsections where there is trust in science and
Yes.
start there. Because if the community has members that do have trust and we try to go over them or around them to create links somewhere else where we are not considered trusted, then we will fall flat on our face as a collective. So I think identifying where trust actually exists and starting there, and then building a very solid, very broad foundation, using and employing and championing the voices of the people in the cultural and community context that do have trust. And then every bridge we build from there will be centered in the community because it's the community members themselves that we started with the foundation.
Does anyone else want to take that question?
Yeah, well, I mean, it was so beautiful. I don't
Right?
know.
That answer was fantastic.
Right.
I don't know what else I can say, but
Say, but the thing I will say is what I even have to recognize, while I'm a member of the community, I also recognize I'm a member of an institution, right? An institution that has done damage for centuries. And to the points earlier that there is still, damaging in relationships. And so not that I feel like I need to go and apologize for the Institute of Medicine or anything like that, but I have to recognize that may be what people see when they see me initially, and that I have to build that bridge. And, along that point, also knowing the history and understanding, or to the best of my ability, and because this, goes across multiple, I don't know everything that has transpired or what, for instance, the Native American population or Hispanic populations. I read and I try to be knowledgeable, Jewish populations, Muslim, all of these things. And even, Black populations, we're not a monolith either, but to kind of understand some of that historical aspect and continue to learn and grow in that way so that when I am faced with someone that maybe not doesn't have the most confidence in, whether it's my expertise or it is us as as medicine as a conglomerate, an institution, I can try to bridge that. So I think that is really important. Is just like, for instance, very basic, Dr. Jamar and I, we have to do CME all the time we things like we know all about heart disease, right? But guess what? We still have grand rounds and go to medical training conferences and learn what's the newest and latest. We should do that for health equity and trying to figure out how to bridge these gaps. Like you have to continually train. You don't do it's not a one shot and done. Oh yeah, I read this book and now I know what's going on. And I did this one training. It is not a one-time thing. It's continually to develop those skills and perfect your craft. And this is what medicine is. It's an art, it's a practice.
So if you don't mind, I want to jump into this trust
Absolutely.
discussion. Okay. So I know that oftentimes when we think about trust, there's usually a conversation about, oh, there's mistrust and oh, there's distrust. And we can, look through history for all of the examples. And like I said, even in more modern times. And I'm going to invite us to also reframe the discussion from just, why don't they trust, right? To, well, why should they trust, right? What are we as institutions and clinicians doing to be trustworthy? Right. So I think that if we start there, then the trust will come because the trust is earned, right? You don't just automatically get trust. And like Anna said, in some instances, you need to repair the harm that was done so that I can trust you. So that's where the work of the AAMC comes in, where there's 10 principles of trustworthiness. And, Dr. Onoma said it earlier, that the community is right the solution. That's actually one of the very first principles. If you look in at the 10 principles, the very first principle is the community is already educated. That's why they don't trust you, right? Because you coming in like, oh, look, I got what you need. Okay, actually, we're
We
good.
know what we
right,
need.
exactly.
We
So
know
you
what we
have a seat and and basically learn something. So I think that, the way that we enter communities is really important. And so instead of always entering into communities with dangling a carrot, because you want them to enroll in your study. You want to get that letter of support for your grant application that's due next week. Actually, what we should be doing is entering communities to just naturally have a investment in the health priorities of that community. Going to the Ward 8, health, committee meetings, any meetings. It doesn't have to be specific to, I just mentioned that because I'm in DC, but it could be any meetings that are convening of community members, and you having a presence there is so important because it's going to show, oh, look, you know what? Time and time again, we keep seeing you, showing up at these meetings, and you don't always have to say anything. Actually, don't say anything. Sit back, listen, develop relationships, know who's who. Then when it comes time for, intervention, they'll think of you, right? They'll want to engage with you because they know you, they've seen you, right? Now it's time to do a health fair or do some type of pop-up or intervention or some type of activation. They will gladly want to do that with you because they've seen you visibly investing in their community. And that's what that looks like. And I will say, I know about funding and timelines are tight, but that's the thing, just like Dr. Onoma said, she's a member of the community. I'm a member of the community. And so, and that's where kind of like that navigation of like being a community member, but then also being, like I'm in academia too. So I wear both hats, but that's the thing. That's why I infuse who I am as a community member, as a concerned citizen into my work. All of my courses are community engaged courses. My students don't only enter, communities like Ward 7 and 8, east of the Anacostia, where I actually live, to do service, right? Because that already sets up a paternalistic relationship. You only see the community on the receiving end of service. No. We're going to go into these communities because we went to a community event, right? Because again, we value community. So I think just reframing our relationships to community will go a long way in repairing harm and then showing and demonstrating that we're trustworthy.
Siobhan, did you want to answer on that?
You know what? I mean, because you brought up something about the trust. I also want to point out that trust is bi-directional. And we also, as clinicians, policy researchers, and all of those things too have to recognize that the trust, we also sometimes have mistrust and for the people that we're treating, right? And I know everyone's like, oh, I went into medicine because I wanted to help people. But guess what? We come in with our own biases. We already form these, preconceived notions of what is going to be like when we enter a visit. And for instance, there's research that shows that how, for instance, Black patients, when they are in a visit, they're interrupted, I forget the exact number, but X amount more times than other patients. And so, and why is that? Or why is it that if, a patient of a certain complexion is in pain, we feel rate their pain score than someone else. So that comes from our own biases and our trust. And so we have to recognize that too. And I think if we don't go into the community with the spaces and knowing that our own, mistrust, for instance, in some of our experiences, our patient populations and things like that, I feel like that's a missed opportunity. And it's not so much just this one-way street. This bi-directional trust is really important.
Absolutely. I mean, I think there's one thing that I'm really hearing from you guys, and that is letting the community lead the discussion and having the discussions. Either way, it's the conversation that goes both ways. And whether that's in the doctor's office or in the community or in the waiting rooms or the exam rooms, it's having the conversation peer to peer, community member to community member. When I think about the name of our organization, blackdoctor.org, when I talked to the founder, Reggie Ware, he says, well, in the Black community or in communities in general, when you had the doctor in the community, that was the trusted voice. That was who you listened to. It was the Black doctor that you went to, and they would give you the information, and you took that information and you really, you knew you could go and ask the questions and get that trusted information back. And I think that is what I'm hearing is like some communities, there's not the trust and we have to start and build from it. In other communities, we have to put ourselves back into those neighborhoods and start letting people know we're here, we're listening to you, we've got the questions, we're going to give you the answers we have as truthfully as we can, and we're going to let you make the decisions that you feel the most comfortable with the science that we can provide and the facts that we can provide, and you can take it from there. So that's really powerful information right there. So one thing I want to ask, Dr. Jamar, when it comes to reminding people about trying to get the increase in the uptake in terms of the amount of vaccines that are happening, what do you think that we can do when we talk about people that are saying, I don't want to take this vaccine? I took the other ones, I got my boosters and everything. Are you seeing that there's a fall off as we come with more vaccines coming up now and everything? Are you seeing a drop in the amount of people that want to take it for different, I guess now maybe I'm speaking directly about COVID, as we have new variations and things? Do you see a drop off where people say, I did the first shot, I did the boosters, now I'm hearing about the variants, the mindset? What are you hearing from your patients about what's their mindset on that? Is it just fatigue about even hearing about it?
That's a great question. And, when you asked that question, it made me think about a quote, and I'm going to paraphrase this. So, it's a great author, scientist, a British, and he says that any advance in technology is indistinguishable from magic. And
Okay.
realize that the way we operate now in today's society with AI, with technology, to some people, that's magic. And it's
Okay.
hard to explain that in a scientific way that people can understand and comprehend. And so we have to realize that we are operating in a new digital world. And the way people receive information, who their trusted sources are in this social media lens, is much different than it was decades ago. And so now it's about breaking down those barriers and having those conversations and realizing and sharing sources. And so I do meet patients who are fatigued, who don't understand, why am I getting this? How was this developed so fast? And now it's about having those conversations, sharing sources with them, trying to find time. And I would want to make an excellent point. Why my colleagues have made great examples about clinicians and having talking to them and the importance of that. The system is not designed for that. And there's a burnout on physicians, clinicians, and the expectations that we have to do more with less. And until we break down and build a system that values this, it's going to be incredibly difficult to achieve these goals.
Anybody want to respond to that? Or just snaps and claps?
Absolutely. Absolutely.
Clock it.
That's what I said. I get it. I get it. I mean, I just came from a busy clinic this morning and, I'm like, oh, wait, what? I got somewhere to be. No.
Yeah.
So absolutely. When we have a system that, reimbursement, time, the prevention, we say one thing, but do another. We're saying prevention is important, but the system is not built to actually focus on prevention, right?
Appointment times are short, workloads are heavy.
Exactly. So, and again, but that's another way where we need to collaborate across, sectors, public health, policy, physicians, honestly, having more clinicians and folks that are in these senior leadership positions too, that can speak to the need to really shift this focus and, having that expertise at the table is really important as well.
The one thing I'll add is, and we all know that the system is operating as it was designed, right? So thanks for bringing that up. You're right that it is, designed as in a business model. And so instead of a public health one. So in the meantime, I do think that relying on, like Dr. Onoma said, the entire clinical team. So we take the onus off of the clinician alone for being the one to, provide the education and promoting the vaccines. Like literally, let's have a shared responsibility team, right? I got 20 minutes, you got 20 minutes. So you put all those 20 minutes together, that's more time to actually engage with the patient, to actually get their questions answered, so that there actually is unity and immunity.
Well, that brings me to us wrapping up. And I wanted to ask everybody, what is their one message for every clinician to take back to their patients to promote unity in immunity, or just for anyone in general? What is it? Clinician? Is it peer-to-peer? Is it to the patient? Is it to the community in general? What is your one message in terms of promoting unity in immunity? Is it possible?
Yes.
I'll start on the end with Siobhan and work our way back up this way.
Well, I guess I'll answer the second question first. Is it possible? Yes. Once we lose hope, then we have lost the battle. So, so we have to have hope that yes, it's possible. I really think, my one message, as I kind of mentioned earlier, is really more about that individual in front of you and that relationship building. I think that goes a long way. I had the sweetest thing. One of the nurses told me this last week, that my patient was seeing a different provider and they were trying to debate whether this patient, they were going to get a vaccine. And the patient said, well, I'm going to channel my inner Dr. Onoma and I'm going to get it. I'm going to get it. And you know what? So that was a relationship that I have built with this person. I've been with my patient for like 15 years and they understand that, they can, because we've had conversations over the years and I have given them the information and the tools to make that informed decision that, hey, I'm going to trust this and I'm going to go with this. So I think the relationship building is going to be my take home.
I love that. Anna?
So I will second the yes. I do absolutely believe it's possible. I think my takeaway, and this is my sort of a personal mantra, I believe in ripples. And so one of the things that I do, and I think that this is something regardless of the business model design that we can all do as professionals, is create ripples wherever we are. And so when I am not at work and I am not wearing a public health hat or functioning in some sort of education capacity and I'm socializing, I will make it a point, instead of talking about the weather, to say like, oh, my arm's still a little sore from my vaccine.
Ooh, I like that.
Like, how
sneak that in.
And I'm like, I know for a fact these people are not all thinking about it or willing. And so I'm going to, so what have you been up to? How's your day? I'm like, well, and I got to say that for like 3 days, my arm's a little sore. And 2 people were like, I scheduled my show, So that's my thing. Like, create the ripples where you can and just,
I like
but
that's smooth. That's very smooth. I like that. Dr. Miranda?
At GW, the med students actually can elect into what we call scholarly concentrations as part of the co-curricular program. So I love that I get to co-direct the community and urban health scholarly concentration because it really allows for students who would otherwise be so, narrowly focused on the biomedical model alone to really think of community when they're engaging in patient care. And also not just think of community, the fact that they've been engaged in community, all of that training, all of that, those relationships, all of the understanding of the social conditions that, that people live in, literally is at the forefront when you're having that conversation. And I think that that is so important given the discussions we've had today around community engagement, being trustworthy amongst the community, listening to community-led priorities and tailored messaging. So I think that just having community at the forefront is critically important for unity and immunity.
I love that, Dr. Jamar. You got a tough follows.
I would say that we all have a role, and that role may be different, but we all have an important role to play in this. And I have the belief that I am a part of something much larger. And we all want to be healthy, have families, to grow, to love. And it is my hope that I'm part of an ancestry, a heritage. And when I leave this place, that I know that I'm going to make the contributions that I was supposed to make. Is it going to be better? I don't know that. But I have a steadfast and understanding that I did all that I can do for the greater good and for the cause. And so I think we all have to keep that in mind, keep working hard, and understand we're all trying to get to the same.
Leaving a legacy, a health legacy.
We call
Yeah.
those impact goals.
Impact goals. I love that.
Hashtag impact.
Clock it. Thank you so much. I mean, I don't think there's much more that we can say on the topic. You guys really wrap that up beautifully. I really want to thank all of my panelists today, Siobhan, Anna, Miranda, Jamar. Thank you for joining us for this special conversation of unity in immunity in Washington, D.C., powered by Moderna. And I just want to thank everybody for having this very important conversation on vaccines. Continue the discussion on blackdoctor.org. Share your information and continue, as this conversation is not one that's going away anytime soon, as we all continue to work towards building unity in immunity. Thank you.